essentially two presentations here. Simple. One that lasts the stimulation for 18 months and the other one that goes to 24 months. But that's an average because any biostimulant depends on the host, and that depends on the patient. Young patients, do you need a break? If you want a break, I can wait. No worries. But otherwise, I'll be starting to speak over you, and it's going to be a very big, messy room. So I can stop here. No worries. So what it does is, essentially, this is the same product, just it lasts long. And why? Because the stimulant part is made of polycaprolactone, which is a polyester. And have a longer chain, takes more time to hydrolyze and to break up than the smaller chains. Simple as that. Nothing more complicated than that. So where can you use it? And I take these images from the book. So it gives you an idea how the book looks like. You can use it for beautification, rejuvenation, and also for prevention. Prevention, why? Because in some phases, in some patients, you can't foresee what's going to happen, and you can act before it happens. Not with volume, but eventually in improving the quality of the soft tissues. Where you can use it, well, the number one is forehead, not glabella. That's a very bad picture. Okay? You don't use it in the glabella, you don't use it in the eyelids, you don't use it in the vermilion of the lips, because those are places that you don't use biostimulants. Very simple. How does it work? Again, you got the initial volume and the clinical effect by the CMC gel, which gives you the volume immediately. It's a volumizer. Over the next 6 to 12 weeks, 8 to 12 weeks, it starts to go down. And it starts losing volume. And that volume will be replaced by the stimulation of collagen. Collagen stimulation is not a chemical-induced thing. It's physical. It's the presence of particles that creates the collagen stimulation. And that is going to last as long as that's necessary, depending on the stimulation, depending how long the collagen is going to stay. Then you talk about collagen types, because you say neocollagenesis. Neocollagen is a very, very big word for 21 to 23 types of collagen, for which you know collagen type 1 and type 3 are 90%, more than 90% of the collagen we have. And type 1 is the most common one. Type 3 is slightly different, and you can give an idea about this. This was something that was put together from Dr. Nicolau, which unfortunately is not with us anymore. And we know that type 3 results from inflammation. You have a wound, you have a trauma, you have a laser process, you have a radio frequency, whatever it creates a trauma. Then in that case, it's a thermal trauma. Here, it can be a physical trauma. And that creates you the production of collagen type 3. If the inflammation is well contained and low grade, progressively you start producing more type 1 over type 3. You don't select one or the other. You don't stop one, you don't get the other one. It just gets more on type 1. And type 1 is a very mature collagen. So what you want in the good biostimulant is to actually get more type 1 than type 3. But that depends on the physical properties of the particles. Well, carboxymethylcellulose is a very common gel used in different products in the market. It's a cellulose, and it just goes away with hydrolysis and enzymatic action. With ELLANSE, which is a good thing, is you have a very high G prime. But high G prime, at the same time, it doesn't work in the same way as by compression as hyaluronic acid. Because in gels, and I think the best example I can give you is ketchup. If you start shaking the bottle, then it flows. If you just turn it around, it doesn't flow. Here is when the syringe, if you apply pressure, it makes it flow. And once you overcome that threshold pressure, it flows easier. With carboxymethylcellulose, it's like a laminated structure. So once you start pressing pressure, it has a very high shear force and elasticity. It goes on, easy to inject, and then on the other side, it goes back to where it was. That's the major difference from carboxymethylcellulose to hyaluronic acid, is the G prime is more adaptive for the injection than the hyaluronic acid in most of the times. And then it degrades very simple, because for hydrolysis, these microspheres of polycaprolactone it looks like an egg. We have a shell, smooth, uniform, and the inside is more jelly. Water goes through these pores and starts to cleavage the polycaprolactone chain in small pieces that will come out from the pores and go into the Krebs cycle, end up in CO2 and water, like any polyester. The difference is you only can get more water inside the sphere if you can have more polycaprolactone out, because it's just occupying volume. As it goes, the progress goes faster. On the second phase, you don't have any structure to hold the sphere anymore, and it collapses. What we know is from biostimulants, and I put the names here so we don't really, because it's just called the elephants by their names at least, is the particles, the stimulation of collagen depends on the physical aspect of those particles. Smoothness and roundness has less inflammation. Polylactic acid is not round at all. And you can have sculpture, you can have Ghana. It's not, you can have Laluma. It's not round. It's flat and irregular. It's more pro-inflammatory. Gives you essentially type 3 over type 1. That's why after 24 months, suddenly you got the results going down. But they're pure biostimulants. With ELLANSE, because you can keep the smoothness, it's going to more on collagen type 1, because the sphere keeps the shape. Calcium hydroxyapatite is compactated. So with time, it starts to erode. And when it erodes, it gets flat and angled. And you got, again, more type 3 than type 1. That's the only reason for that. In terms of injections, that's the guide as these injections, and that's what you're going to do. So I'm not going to get much on detail this, because I'm going to talk about it. Devices. Please don't use 27-gauge cannula with any filler. It's very, very dangerous. It's like a needle without control. So 22, 25 is great. With ELLANSE, you want to spread it. You want to increase the surface of contact with the soft tissues to get biostimulation. So retrograde fanning is the best idea. But in certain areas, you need to use bolus to get that lifting capacity. Limit to 0.1, 0.2 maximum. And I'm going to show you how much is 0.1. It's a lot. You're going to see it. And like this small difference, avoid me having nodules. Because nodules is too much tension in one place. Low pressure, this is exactly the same for anything. It's not inventing the wheel again. It doesn't come with lidocaine. I don't need lidocaine to mix with it. I don't use it. I just inject straight from the box. But if you want, you can maximum 0.2, because more than that, you change the rheology, you lose. It's not ELLANSE anymore. It's something else. And we are not allowed to fabricate drugs in our office. And if you put more than 0.2, it's going to be a drug. It's not ELLANSE anymore. It's not a medical device. Well, in terms of volume, depends on what we need. There's not a cookie cutter also. And the truth is, in areas that you have soft tissue coverage that is not very strong, periorbital, pre-jowl, the nose, undercorrect. Like Dr. Luis Ayala has told you today, undercorrect. You can always add. You cannot take it out. And you and me, us as physicians, you are the antidote. The antidote is about planning and doing it as you know and as you want. But again, remember, you can always add. It's much easier. Hyaluronic acid is the same thing. You can always add. Taking it out is much more complicated. You have no control of what you're doing. And the other thing is wait 8 weeks. The bottom line is the most important one. 8 weeks before you top it up, because you need to wait for that collagen stimulation to come. And you're not going to need to do as much after that. Well, massage, you do it immediately after, and that's it. And where do we inject? Again, subcutaneous and supraperiosteal. You cannot inject anywhere else. So again, the same thing. Which patients to select and to start? Start with a patient like this. More mature, that can actually benefit from the collagen stimulation. Good soft tissue coverage. And where to start? Mid-face, jawline. Don't start with the nose. No, because it's not because you don't know. It's not you know, but it's because you don't know the product still. You need time to get to see what it gives you. So give a break to yourselves and go in a safe way. This patient, for instance, we cannot have a result like this if you don't use a biostimulant. Because the jugal area, there's no bone support. So you need to improve the quality of the soft tissues subcutaneously, and that's what it gives you. And that's 24 months afterwards. This gentleman for the jawline, 3 ml, chin and jawline. And this is what you're going to see in the book. Injection guidelines. You have what we do, the difficult level. Difficult level is not because it's more difficult, it's because it's less predictable if you go on and need to get more experience to get there. That's all. And this is what we have done. The chin. Options for the chin. This was someone who lost a lot of weight and just want a minor adjustment to her face. 3 ml placed on the mid-face and zygoma. Protocols for the mid-face with needle and cannula. Protocols for the zygoma doing cannula, like RAMI have done it. Simple. This is a typical workshop patient. Free flow of syringes, 10 ml. She's a candidate for a surgery, but she shows up, and once she shows up, we start working, right? And we did temples, mid-face, jawline, marionette lines, even we did the lips, not with ELLANSE, with something else, okay? But the results, especially if you see on the jawline, there's no threads, there's no surgery there. And these, you have to wait 3 months to get that result. If you don't wait for those, you don't get it. And for the temples, well, we use what we discussed yesterday about superficial, under the superficial temporal fascia. And this is the video I showed yesterday again. This is subcutaneous, that's the superficial temporal fascia, that's where we place the fillers. And this is not a cadaver, is a patient that is alive. You can see the artery is actually there, the superficial temporal artery, on top of the superficial temporal fascia. For the jawline and for the marionette lines, again, it's not inventing it. The thing is, you have to place it thoroughly what you need to do. And this is another patient, 1 year after. The thing is, I just want to show this. She did the removal of the buccal fat pad. And it's something, personally, I'm not very favorable to it, because you're going to need it later in life. And this was able to do correction with ELLANSE. With other products, if it was not a biostimulant, we'll not be able to get this. Because this is subcutaneous. It's probably the most difficult area to treat, because it just goes inside, and there's no bone support on there. Then, complications. Well, these are not complications. Unwanted cosmetic results, poor cosmesis, is not a complication. It's bad planning, bad execution. And usually, it's overcorrection and misplacement. And overcorrection, especially the hyaluronic acid fillers, you see people using huge amounts. Cookie cutters inject these points, this amount per point, and everybody looks the same. They look like a balloon. You take all the individuality of each person, and you need to address them. This should be tailor-made. That's why you do it. So, but the adverse events are essentially this. And this is from 2010 to 2020. And this is what was reported. Doesn't mean that's exactly what happens. How many of you have reported a complication? 2, 3 people in a room where people inject? 4? You need to report things that are unusual, not swelling, not a bruise. No, really complications. And most of them are nodules. Why? Technique. So nodules is the reason of nodules is excess tension on the tissues. Anything that you place on the tissue that creates tension creates a nodule. That's why you have nodules with any product. Biostimulants, you can have more nodules. Why? Because you're going to concentrate all your stimulation in one point. And what you want is to spread it, not concentrate it. So avoid bolus, and you avoid 95% of your nodules. Treatment, if the early one is CMC gel, you can spread it. You can even drain it. But if after 2 months, it's a true nodule. And then you have to do interlesional treatments or even surgical removal. But Nodules and granulomas, and that was I was very close to say something on one of the previous talks. They're not the same thing. And we tend to call the same thing to nodules are nodules. It's a technical mistake. It's written here. This is published. It's not me. Technical error. Too much product in the wrong place. Granulomas is a non-specific immune response. We don't know why they happen. And clinically, the diagnosis is clinical. It's not pathological. If you send it to pathology, they say, is a foreign body there? They say, is a foreign body granuloma, independent if it's a nodule or not. Nodules are dense. This is published. That was radius injecting the vermilion. It's a mistake. It's not supposed to. So what happened with doctors? Oh, I don't like radius because you got a nodule on the lip. You're not supposed to do it on the lips. This is Restylane. That's a nodule. Too much superficial. That's a cystic granuloma. It's an inflammatory process. You can see it. The treatment is different. This you can treat with steroids or anti-inflammatories. That one probably you have to do it intralesionally because oral or systemic is not going to work. This is ELLANSE. So people asked me yesterday in the workshop, what about the neck? Well, the neck you have to be careful. This was people trying to make it weaker, so they diluted it. If you add water to anything, well, to a coffee or to a tea, you dilute it. It gets that strong. Into a filler, you don't dilute it because it's not going to get weaker. The power of stimulation is the same. It's particles. The numbers are the same. They don't dilute. What you're diluting is the gel. What you are making is more spreadable. But they migrate and they move up. You have less control of what you're doing. So anyone that dilutes is asking for trouble. That's my statement, and I can go on this for the whole day if you want, but let's do it on the side. But this is ELLANSE wrongly done because it's not indication to treat. It's off-label. Swelling. Well, we can have swelling, normal swelling, and have persistent swelling. Persistent swelling usually happens in the periorbital area, like with any filler, and usually is because of lymphatic impairment. Too much volume, too much pressure, and you have a problem there. If the patient is a smoker, that's a problem. If they have done surgery in the area, that's a problem because the septums and the orbital septum might be compromised. How you treat it? General measures. Sometimes just time. Granulomas. Well, we don't know why we cause it. We can always discuss about it. Biofilm, definitely I don't think is an important thing. That's all the question marks there. But usually there's a trigger factor. An infection, upper respiratory tract, GI, urinary, a minor procedure. Most of the times it's dental procedures. And it can just trigger a non-specific inflammatory reaction, and all at the same time they show up. So how to avoid it? Well, it's very difficult because you don't know what it causes it, so we don't know really how to avoid it. But you know that if you avoid these things, probably we have less chances of having a granuloma, but that's it. How you treat it? Well, there are so many different treatments, means that nothing really works. So what I think nowadays, you have to combine them. Another proposed treatment that is being more effective using methotrexate, 5 milligrams per week, but you have to supplement with folic acid. You're a dermatologist, most of you, you know how to treat psoriasis and autoimmune diseases, that's how it goes. Remember, there are different things. And then the elephant in the room, vascular complications. It's accidental. It's not related to the product, it's related to the injector, and sometimes bad luck. But some people have more bad luck than others, then you have to look into it. How to prevent it? Well, we've been talking about all this all day, so I'm not going to really give you a problem with it, but how to treat it. Everything is possible. Use everything you want. It's an emergency. And what you want is to avoid let me go back one. What you want is to avoid the number 8, which is necrosis. How to avoid it? Early diagnose is the most single important step. Diagnose it as early as you can. How you do that? If you treat, that's why I do it. I don't mean I'm right, that's what I have. If I treat the area that's more prone to this, I have my assistants calling the patient later in the day. How are you? Any pain? Pain is a very good indicator. Any discoloration that went away? Please come back. I want to see you. Might be coming back to the clinic for no reason, but better for no reason than for a bad reason. One thing I do think is Trental, pentoxifylline, is a very good and cheap medication. That's what we use for insufficient peripheral artery, for peripheral arterial insufficiency. It does work quite well. But this is the most important part. Okay? I think I can resume our presence in the Congress to these 3 words. And this is my motto. Is ELLANSE for everybody? Definitely not. Definitely not. If someone doesn't understand which kind of result we are offering, don't do it. If someone says, I'm not sure that I'm going to like my nose, I start with hyaluronic acid. I don't know if I want to get bigger cheeks, start with hyaluronic acid. Not because you can melt it, it just doesn't last as long. As simple as that. Because you never can melt it. And these are the advantages for me when I'm using ELLANSE. These are the disadvantages. Would I love it to be reversible? Yes. Is it? No. But we have to work with it. Thank you. You have a patient for injection. RAMI is going to moderate. I'll try to be as fast as I can so I cannot delay your lunch.
They are getting a little bit hungry. Thank you very much, Francesco. So if you do have any questions, please raise your hand and I'll come straight to you. In the meantime, let's say, Francesco, while you're marking a patient after injecting ELLANSE, doesn't like it, comes back the next day and says, this is too swollen, this is too angry for me. What do you do?
Oh, the next day is simple. Just wait. Let's get some anti-inflammatories. Let's get some ice packs, which is a great anti-inflammatory with no side effects. But the next day is never something. It's probably more related to my technique and my trauma than to the product.
Okay.
But if someone comes and says, I don't like it, I don't want this, means that my consultation was a very poor one.
Okay, so can we please turn the screen to Francesco's model?
I need my glasses, sorry.
So while Francesco, I'm going to answer this, hyaluronidase does not dissolve ELLANSE.
Both.
Francesco?
Yes?
As far as hyaluronidase, does that dissolve ELLANSE?
No.
Okay, so it doesn't.
Why you use it in the vascular complication? Because before hyaluronic acid was in the market, we were using hyaluronic acid fillers. We use hyaluronidase to increase the spread of pharmaceuticals with local injection. We used to mix it with local anesthetic to increase the spread of it. Patients who have extravasation, we're doing chemotherapy, for instance, and there's some extravasation from the veins. We used to get hyaluronidase in the area to also include the dilution and spread it to reduce the necrotic effect of it. And hyaluronidase also increases the vascular permeability to other substances. So I think you are not in a place to hold anything back. And that helps you, the local diffusion of pharmaceuticals.
So yeah, I think if there is a chance or a worry or a concern about vascular occlusion, vascular compression, my advice is whatever you have in that cupboard, just inject it in the patient's face. From saline to hyaluronidase to steroid inject, whatever you have, just inject it in order to and try and massage it as well. We have a nice talk later on about the danger zone after lunch that talks about hyaluronidase and what to do.
Okay. And Rami, on the book of ELLANSE, there's one chapter just on complications and how to handle those. And
how can they get the book?
Yeah, but they're going to have that, hopefully.
Yeah, how can they get it?
I have no idea. We have to talk with the local representation.
Okay.
Okay. Can you remember me?
And there's something called Sinclair College, I'm not sure if you're aware of it, where you have all those talks, all those complications, all the what to do and what not to do that is present. And it's free to register, so it's worth doing that as well.
Okay, you got Dr. Raki here, which has a beautiful face. And yesterday you were in a workshop and you start discussing about small things that you can improve. And again, using the same plan you did last time, is you can see that there's a face that is essentially longer than wider. And we have a good symmetry, although the right side has a bit less volume than the right. Minor, but yes, it is. Thing is, even if you don't correct, you need to point it out so the patient can be involved in the treatment plan. If we look to the temples, there's a very small, can you turn a bit to that? Thank you, Dr. Wright. There's a very small loss of volume here, or probably there was never volume there. You can improve it by adding a tiny bit over the eyebrow to give some support. It's not a temple problem, it's not a temporal problem. Can you turn a bit more?
I think it's worth moving the camera a little bit forward. Yeah, perfect, that's better.
The
there we go.
Yeah, better than this. Both. And white also. Good. Okay, let me mark it in red. So we can give a bit of support over the brow. The advantage of ELLANSE here is because of the biostimulation, you can have a long-lasting result. And you just want to get this. Not talking about this. This. Talking about millimeters, not centimeters. And then you can see, can you give me a good smile, please? Very good smile. Nice volume on the cheeks, special animation, and you don't see much volume over the zygomatic arch. So definitely you can improve that. Can you relax? For the zygoma, I feel the upper edge of the zygomatic arch, I mark it, the lower limit, and I mark it. And what we see when I do this, there's a bit of a depression over the preauricular area. So we can definitely bring it slightly lower to have a good soft transition. Otherwise, it gets a very sharp zygoma and gives a bit of a strange look, like a maleficent look, not to say something else.
What levels would you place your ELLANSE here?
Oh, it's supraperiosteal, like the same thing you did with Miley.
Supraperiosteal. What are your thoughts about, we want the collagen stimulation. Do you think if we injected supraperiosteally, we're going to lose a little bit of that collagen stimulation?
No, because collagen is produced by fibroblasts, and fibroblasts are everywhere.
So exactly, so it doesn't matter what level, you will still get the collagen stimulation when you're injecting ELLANSE.
Good smile again. And when Dr. Raki smiles, you see the volume stops here. One of the reasons I don't really like, I like to see the animation is, can you relax? If you extend it medially, you're going to inject an area that already has volume, and in animation it gets even more volume, and you're going to get someone with the big cheeks and the eyes just become smaller. How many people you have in your office saying, doctor, I don't like my eyes look smaller after I've done the fillers? It's because of this.
So when, especially the mid-cheek and the lips, I find when you want to assess the patients, make sure you assess them when the patient is still and when Francesco, what he's doing when the patient is smiling, because you've got movement and you don't want the muscle to push the material you place to a place you don't want it to go.
The other thing I'm doing, see, I'm using my finger to see where is the orbital rim. The orbital rim is there. I need to mark it because one thing you are sure, you don't want to go above your orbital rim. Above the orbital rim, you're on the eyelids. Then you can ask the patient to look down a little bit, and you can see the upper limit of the nasal fat pad. You don't want to go there also, because that's where you got volume. If I put more volume here, I'm going to increase the depth of the nasolabial fold. And there's a small gap of volume right over there, because got good volume here in this area. And the only place I want to fill is where I got the white markings. And for reaching there, I just need, like RAMI did, 1 point. And I can definitely go with a cannula, supraperiosteal, and supraperiosteal to the tear trough. It's not a true tear trough, it's just a volume loss. That's all. And you're just going to slightly improve it. Here is one of the areas that with ELLANSE you try to undercorrect. When you say, okay, I might need a little bit more, you stop. With hyaluronic acid, you continue. With Mali, you bring it to full correction. Here, I stop. Then we saw, if you fast forward Dr. Raki 30 years, this is what's going to happen. This is what's going to happen. See? The jowl is going to show, the melanite line is going to show. What we see is that there is already a small pre-jowl volume loss. Someone with a more saggy skin, I'll go and treat the melanite line even preventatively, even without being there. I give support. In her case, I just need to treat the pre-jowl to get a bit of volume. So, and we don't want to raise the line. I want to lower the line in the pre-jowl so she has a straight line. For that, just going to use 2 small points, 2 small bolus of ELLANSE, 0.1, 0.1, from underneath to increase the length, not the lateral projection. Okay? Simple as that. So how much I'm going to need to cover all this area? Maximum 2 syringes per side. Maximum. Okay? So let's do it. It's local. You can have one small needle.
Do you have any questions while we're doing this?
This is too big for local.
Nope.
No, it's fine. Personally, I'm very fond of local anesthetic with adrenaline. Just going to do a small needle prick here. Okay, just 1, 2, 3. That's it. Sometimes, do I do this in my practice? Usually no, but someone is in front of the camera, is on stage, is a bit more afraid. Let's give some comfort, especially when they are colleagues. Okay, and I'm going to get you small. Actually, here I'm not going to give you anything. I'm going to use needle for the eyebrow, cannula for the mid-face, needle for the pre-jowl. Let's start with the needle.
Are you going to use ELLANSE S or M?
Good question. S.
S.
Why S? Because that's what he's giving me. No, I'm joking. Start with S for a very simple reason. Is you want to know how much volume and how long is that result is going to last. Start with S. M is great for men. We are chicken, we don't like pricks, and you don't like to come back often to treatment, so if you have a man, go with M, definitely. Or if someone from another city, from far away, go with them. But try to build your experience with
What are your thoughts about using ELLANSE in the neck?
Sorry?
ELLANSE in the neck. What are your thoughts about it?
I think there's better option for the neck. Okay, I got my hand here. I'm going to inject 0.1 on the back of my hand. You're going to see how much is... Can you focus there? You're going, yeah, here? It's okay, perfect. You're going to see how much is 0.1, okay? I'm going to start injecting.
Our organizers are worried about the waste of material.
Don't worry, you know why? Someone is paying for it and it's not you. This is 0.1. So when I tell you 0.1 bolus, not more than this is how big it is. Okay? I'm going to feel a small, small needle prick here. So going to the... I'm going to go straight, one small prick, 1, 2, 3. I'm in the bone.
Why do you not aspirate here?
Why?
Do you not aspirate?
Because it doesn't give you any, in my practice, in how I do it, it doesn't give me any advantage. If I got blood coming in, I don't know if I'm sure I'm not inside any vessel. Mm-hmm. No, I'm sure of it.
Okay.
The thing is, I need to keep it in the bone.
But have you ever had, you know, let's say not in this area, when you're using a needle, do you get blood when you aspirate? If you do aspirate?
No, I tried. The thing is, I stopped aspirating because I was aspirating a lot, and I didn't get anything out of it. And I was actually, I'm not able to get the needle in the right place. I'm not as good as you, man. You are able to get the needle in the place. I can't.
No.
And I'll be scratching on the bone, and that's painful and gives more. If you scratch the periosteum, that gives you swelling.
And by the way, just for you guys to know, when you aspirate and you don't get any blood, that doesn't mean you're 100% safe, because you could get false positive, false negative, right? Is that what, yeah, false negative. So even, I mean, if you get blood, then you're definitely in a vessel or an artery. But if you don't get blood, that doesn't mean you're not in a vessel or an artery. So you still have to inject very, very cautiously, which is very, very slowly.
Okay, can I have, let's keep this one and get one with the cannula. So, yeah, I need another syringe with the cannula. But this one you can, anyway, let me do it. Because I'm with the needle already, let me just go down to the pre-jowl, okay? You okay? For the pre-jowl, what I feel underneath here is the posterior border of the mandible. So if I'm going to do anything behind this line, I'll be actually on the floor of the mouth. So you have to get your finger, and that's my limit. And I go right from there. One small prick, 1, 2, 3, I'm in the bone. I cannot go further. Point 1. See the plunger? I inject so slowly. Look. And I go for another one, 0.1. Very, very slowly. That's it. You see, there's 2 small balls. You massage against the bone. The bone is your friend. Okay, let's show you before we do anything else. Can you just? Okay. Good. Let's go your cheek now. No. I got anesthesia. I'm going to start with the cheek, with the zygomatic arch. Remember, start from lateral to medial, deep to surface. Okay?
Up to down.
Up to down. Here I cut a little bit. I went down, but there's nothing there you can actually change. Let me prime it. Let me show again. Let me waste a bit more of product.
There we go.
What I'm going to do inside is this. Lines like this. Look. That's it. Okay? You can do 10 lines of this. It's 0.05 per line.
At what level? What level do you place that?
Supraperiosteal. Or as you say, as deep as I can go. Well, in the meantime, the hole closed. It's okay, it's okay. When you open a hole, just make sure you go through the dermis, that's all. Thank you.
This is a 25 gauge cannula.
25 gauge. I like to do the lift as to pitch as RAMI. Instead of pushing the cannula, I just drill it like this, and it just goes 1, 2, 3, goes there. And I am back there. You cannot see the tip of the cannula. Can I go deeper? Yes, I can, because I'm not still satisfied. Now you're going to hear some noise now. 1, 2, 3, there it goes. And when you stop, you go a little bit further. And you just fan. See, the cannula moves fast. The plunger moves very slowly. It's about being more soft with your technique to reduce swelling, and you can apply this to any filler. It's not specific of ELLANSE. Good. Because I didn't mix with lidocaine, Dr. is going to feel a little bit of a burning sensation, but that's all. Point 0.5. Okay. Have the needle again. And now we go for the mid part, the mid-malar area. I just want to go there. I can do this with the needle, like Dr. Jamil have done. Yes, I can. But I have already a hole here. I can use a cannula. Let's do it with the cannula.
Would you use ELLANSE for tear trough?
Not for the tear trough as most people think about it, but for the supraperiosteal area, definitely yes, because that corrects the tear trough. But we're going to talk about it later, I think. Tear trough is a matter of anatomy. It's volume loss over the malar bone. The orbital rim gets wider. That's why you lost support, and you start to have a groove. So you just go back to the supraperiosteal level, give the support, replace the volume, and the tear trough is corrected automatically. And one of the things you see, I'm trying to get out of I don't want to be in the front of the camera, so let me just get my... Can you turn to me a little bit? I'm gonna get out of the way. I need the needle again, please, sorry. You okay? Yes. Patient is still alive and smiling. Okay. When you go in this area, to make sure a supraperiosteal, there are 3 steps. At the lateral contours, you feel a resistance. You're going through the retaining ligament of the orbicularis oculi muscle. Mid-pupillary line, you feel resistance again. You're coming out of that space, the parazygomatic space. And the orbicularis oculi inserts directly into the malar bone and orbital rim in the inner contours. You cannot put it underneath it. So you stop before that. Okay, so you're going to feel, okay, my candle comes out again. Let me go again. There you go. There's a point of resistance right here. 1, 2, 3. You're going to feel something strange. There we go. Then it just slides. Second point of resistance. That's it. You lift the cannula. You cannot see the tip. You cannot see the tip, see? It's like a fishing pole.
As deep as you can.
It's painful.
It is uncomfortable, yes, because you're on the periosteum. And I start injecting very small quantities and very slow. And immediately you got the correction of the defect. And then I just move it up a little bit to go on the side, and you protect the orbital rim with your finger. My finger is in the orbital rim. I don't want to go over there. And I put a little bit more. And I put 0.1.5. Come out, massage. From the same point, that was supraperiosteal. You can go a bit subcutaneous now in the lower part. Why not supraperiosteal? Because it's too deep. You have to place a lot of volume there. You just need support to the subcutaneous area.
Would you mix it with lidocaine?
You can. I usually don't. I stopped doing it. That's it. Let's clean the face. Yeah. Let's clean.
Can we have a look
Some,
at the before
alcohol.
and after?
Thing is you're not going to see a wow result. You know why? Because the patient has no drum on their face. So why should we have drum?
Yes. We have a question.
ELLANSE should not be put on the bone or the periosteum because there is no fibroblastic activity over it. So why are we putting it on the bone?
There is fibroblastic. We do get collagen stimulation when we place a supraperiosteal because the fibroblasts are present supraperiosteally as well. So yeah, we could get that as well.
Look, the brow, the left brow was lower than the right. You got support to the lateral brow. There's more harmony on the mid-face, and the pre-jowl is not as obvious, but we didn't do anything there.
And the nasolabial improved without even injecting it.
But that's the trick, because you enter on the zygomatic cutaneous ligaments to stretch them up. So sometimes we need to do a small bolus in around the piriform aperture to get the support of the upper third, but she does need that in this case.
Fantastic. Well, thank you very much. That was beautiful.
Thank you.
Any questions?
Any questions from the audience?
It's a bit chubby. Let me do the other side. Yeah, beautiful. Let me do the other side.
We don't have time for
Thank you very much.
Let's do the other side.
I would like to request Dr. Faiza Khilji to come on the
this one,
stage
this one.
and give us small momentum of appreciation to our distinguished speakers.
Small prick, okay.
Dono. So first, Dr. Rami Haider.
Yeah?
कोई बात. No.
Bone.
Rami Haider.
Can you change the needle, please? Just change the needle, it's blunt. You okay?
So again, I'm going to make an announcement for the basic thread workshop. It will start at 3, and all the trainers should also come to the training hall at 3, so that we can finish it in time. There is a lost keychain. Anyone who is searching for his keychain, it's a Corolla car. See this keychain?
Okay.
It's at the reception desk. So we are going for lunch, and we'll come back here again at 3:15 sharp. 3:15 sharp.
Cannula now. Another one with the cannula to do the sides. Yeah, no, keep it there.